Good evening. This is Dr. Balaji Ramani, Director of Oncology, Gleneagles Hospital and Cancer Institute, Chennai. Today's session is going to be about the World Cancer Day, which is celebrated every year, and I use the word here as celebration on February 4th. The theme for the World Cancer Day, as provided by the WHO, is United but Unique. So, what does this mean? All of us, as either caregivers in the form of doctors, nurses, physiotherapists, in the form of dietitians, from the place the patient enters the hospital, right the time they leave, from admin to security, everybody is united in the care of the patients. Along with this, we also have the fact that each of the patients are going to be unique. Now, all the guidelines in cancers are devised on mass numbers, meaning we take data points, we take studies of large number of patients, see how they respond to particular treatment, and then we advise on the treatment. Let's say, for example, we have a patient with breast cancer. Do we do surgery first? Do we give the patient radiation or not? Can we plan chemotherapy for them? Can we avoid surgery? Can we do a less mutilating surgery? All these aspects of care are going to be decided by the entire management team. At the same time, though breast cancer is considered to be a single entity, each patient with breast cancer is a unique patient. The tumor biology is different. At a molecular level, they are fundamentally different, and these can be measured, and that is why the World Cancer Day theme is United but Unique. Will be also a little different in that we are going to talk about not just about cancer care and treatment. We are going to talk about a lot more in terms of coordination, communication, and continuity. These are important things much more than what we realize. The treatment part, the algorithms, all of these are pretty well known to almost anybody who is dealing with cancers in their day-to-day practice. We have a lot of guidelines, we have a lot of studies, we have doctors groups who deal with this on a daily basis. We have multidisciplinary tumor boards where the patients are discussed, and like this the treatment of cancer proceeds. When you think about coordination, of course we all know that from the time anything is being done in the world, it requires coordination. Just let's take the example of this meeting. So to set up this meeting at 4 o'clock and start a live stream, we need to realize that there is a set time, there should be a platform. The backend team is working to allocate the time and book the appointment at that particular point of time. I have to finish my OPD and my IPD and OT commitments before then and have to be here. The entire team of nurses, coordinators, the AV team, everybody is working to make sure that I'm connected and live before you at 4 o'clock on the World Cancer Day. So Feb 4th at 4 o'clock, that was the plan. And we managed to do it on time. And this requires a lot of coordination. Now, if such a simple thing as going online and starting a show requires so much of coordination, then the treatment of a patient with cancer needs to be much more coordinated. As simple as deciding when a patient is going to start therapy, what kind of treatment he needs, what kind of additional treatments are required. All these require coordination between multiple teams. Other than the routine treatments which are being provided by many of the other specialties, I'm not belittling any of them. All treatments require coordination, all treatments require care to a greater or a lesser extent. When we take cancer in particular, it is a multidisciplinary treatment as a whole, much less when compared to other specialties. When you look at it, this is required much less. For example, in cardiology, most of the patients who come can be treated by the cardiologists themselves. Only when a certain scenario happens, they have to approach the cardiothoracic surgeon for help and a surgery is planned. And in a similar way, the cardiothoracic surgeon can handle his patients, and beyond that, the cardiologist may not be needed after the first initial period that is going to happen. On the other hand, in oncology, there are three pillars. Our team, Triumph Oncology, is a representation of the same, meaning we have all the three as part of a single team. So we have medical oncology, we have radiation oncology, and we have surgical oncology. All three are something like Trishul of cancer treatment, the trident of cancer treatment, and help in the triumph over cancer. Coordination between these three teams is always paramount wherever you go for treatment. Common cancers that we take, for example, oral cancer in India, in gents, in gentlemen, in males across the world, and especially in India, this is one of the most common cancers in India and Southeast Asia. Happens due to tobacco use. So when a patient comes with a oral cancer, what is the next step? So the first step is going to be the coordination with the anesthetist to make sure that they are available for planning for a biopsy. A lot of times they will have painful lesions, so it cannot be done under local anesthesia. You will need to plan for anesthesia. And when compared to other specialties, oral care anesthesia is going to be slightly different. You cannot always put an oral tube. The anesthetist agent which is going to be given, usually whenever general anesthesia is given, the tube is put through the mouth into the lungs, into the tube that goes to the lungs, the windpipe. But here, we cannot actually put the tube through the oral cavity. In a lot of cases, we'll have to put the tube through the nose. So there itself, the difference is going to start. So the anesthetist has to be made aware that the patient has got difficulty. There is a big tumor sitting there, and it will be a little more difficult for them to do. And in some cases, we may even do something called as a tracheostomy to get the airway inside and give the anesthesia. As simple a procedure as a biopsy, which gets done so easily in other settings, like say when the patient has got a gastric cancer. We just need to put in an endoscope under local anesthesia, just spray some anesthetic agent, go inside and take a biopsy. On the other hand, in head and neck cancers, we need to coordinate with the anesthetist, make sure that they are made aware of the fact that the patient cannot open the mouth widely or they have a lot of pain. So you may need either a nasal tube for anesthesia, or you may need to do a tracheostomy for starting anesthesia. Right. So you do the examination under anesthesia, and you do a biopsy to get the report. And once the report comes, then you start the next line of treatment. Here again, many times we may need to go for, in advanced cases, we may need to go for chemotherapy. So our medical oncology colleagues will come in and we refer it to them. We ask them to see the patient and time the chemotherapy. Now, chemotherapy usually will be delivered once in every 3 weeks. Let's say the patient starts on a Monday, every third Monday from then, they will get the chemotherapy. And once they finish 3 to 4 sittings of chemotherapy, then they need to be brought back to us. So here again, the coordination is going to come. So the patient has to be referred at the right time. Not just that, there are some cases, let's say, for example, a patient with a colon cancer. So with an advanced colon cancer, sometimes we might be giving some agents which will cause more bleeding to happen. And there is a higher risk of what we call as bowel perforation. Openings in the bowel that can happen, in intestines that can happen. Some of the intestines can give way, and there is a higher risk of this particular perforation happening when bevacizumab, one agent, Avastin we call it, one special type of molecular therapy is there, which gives a very good effect in the treatment of cancer, but at the same time, it can cause a higher rate of bleeding and perforations. So traditionally, when we give chemotherapy, we give a 3-week gap between the last cycle of chemotherapy and when we plan for surgery. So let's say I'm planning a surgery towards the end of the month. I tell my patient that you get your chemotherapy by Feb 1st to Feb 7th, not beyond that. And then you can report to me by around Feb 20th, 22nd, and then we can do the planning for the surgery, which will happen in the end of February. On the other hand, if the same patient is getting this particular drug, then my medical oncology colleagues and myself, both of us are aware that this needs to be stopped for almost 6 weeks. It's not the usual 3 weeks. The minimum period is 6 weeks. So this planning and coordination has to happen about one cycle chemo ahead. So it can get missed. It can create problems. So you need to be really spot on. And that is where the communication and the coordination is going to happen between the two teams, between the medical and the surgical oncology teams, where we are going to discuss and plan this. And we'll say, boss, let's do this on Feb 28th. So which means the fourth chemo that you're going to give, you don't give bevacizumab, or you stop after the fourth cycle. The fifth cycle you don't give bevacizumab. After the sixth, I'll be operating. So this is how the coordination and the communication is going to happen in oncology. In a similar fashion, for every cancer, We need to have the sort of everyday day-to-day assessment of the patient and planning of the patient which needs to happen. Same way with our nuclear medicine colleagues, what we call routinely as a PET scan or a PET CT. Now these PET CTs are available widely across India, but we need to know that the patients who are getting a PET scan, more often than not, they need to have a control of their diabetes. There are other PET scans available which do not require that now, but by and large, when we call about or talk about the routine kind of PET CT, we realize that it needs control of the blood sugar. So, in case a patient is there whom we see and we order a PET scan, and that patient has got a poor control of diabetes, then we make sure that we talk to the diabetologist. We put them on insulin for a couple of days so that the blood sugars are around 150 fasting, not more than that. And we send them on that day, and on that day before sending, we measure the blood sugars again for 2 days. We make sure that the blood sugars are within range and we are able to get a good scan. So this kind of coordination and planning is needed in every branch in oncology. Third thing is continuity of care. Now, when we talk about coordination and communication, we need to tell why we are doing some things to the patient, make them aware, and make them part of the decision making process. And continuity of care needs to get established. So, what do you mean by continuity of care? So, as I mentioned, Trishul of cancer therapy or the triumph of cancer therapy is going to be medical oncology, radiation oncology, and surgical oncology. And all three departments need to be given as a continuous process. We as cancer doctors know that in a patient who undergoes surgery, the healing has to happen by around 3 to 4 weeks, after which the radiation has to be started, because studies have shown that the results in patients who receive a late radiation are going to be poorer than patients who start early radiation. By early radiation, suppose I operate in the first week of February, by the first week of March, they should be fit and ready to undergo radiation. So this requires planning the radiation therapy schedule and the department schedule in such a way that there is a slot available for this particular patient to start the radiation therapy. Now, all this involves a lot of coordination and communication. Now, if you take individual departments, let's say even within surgical oncology, we need to plan a lot and do it. Like, for example, as simple a surgery as, let's say, a bowel surgery, an intestine surgery, which requires the removal of major type of cancers. Along with that, we also do something called as HIPEC. So this is hot chemotherapy, which will be given at the time of surgery inside the abdomen. Now, it's a pretty major procedure. We start off in the morning and we'll be going on till the night. And when we are doing this, a whole team is working in the background. Now, when we get a patient for HIPEC, the patient has got a condition like ovarian cancer or colorectal cancer with peritoneal disease that requires this hot chemotherapy within the abdomen during the surgery. Then we start off by preparing them almost a week to 10 days before the planned date of surgery. From then on, they are put on a special diet, a high protein diet. They are started on something, some exercises and all that to improve their lungs. This is all done for other major surgeries as well. I'm just quoting HIPEC as an example. So you start them on a high protein diet. You ensure that they're able to have their breathing exercises and their physiotherapy done. There is a consult which is provided with somebody called as a psycho-oncologist, who is a psychologist who deals especially in patients with cancer, where we can give them some sort of counseling, prepare them for what is ahead after a major surgery, how long they'll be dependent, how long they maybe need to be off food and may require IV nutrition. So all these are explained in detail to the patient and the counseling is provided. And all this goes in before the patient actually even comes for admission to the theater. So once the patient comes, then after that we prepare them and then take them to the theater where the surgery happens for almost like 7 to 8 hours at least. So here our anesthesia colleagues are of great help. Now this is a complex procedure where the patient is going to be having heated water, sort of like saline or D5 or various agents. All the drugs which are given IV, all of them are now given within the abdomen inside the tummy at the time of surgery. So the fan temperature of the patient on the higher side. We try to keep them warm. Warmth is needed. The normal temperature is somewhere around 98.6, as we all know, and we try to maintain the normal temperature for the patient. Now, when this 37 degree centigrade is going to be there, then the patient is fine and they're going to be maintained. And that will be the job of the anesthetist to make sure that the patient is getting warm. Now, during the time of HIPEC, which is essentially hot chemotherapy, which is going to be given at 42 to 43 degree for the fluid which is going to circulate inside the abdomen. So conversely, unlike in many other cases wherever anesthesia is done, usually you will try to warm the patient. Here it is the reverse. You have to cool down the patient. So morning when the surgery starts, the patient will need to be warmed up, and we proceed with the surgery. We do the removal of the organs or the diseased areas whichever are involved with cancer, and all this time the temperature is kept on the higher side so that the patient is kept warm. Now, by the time we reach a phase where almost the complete removal of the tumor is done and we are about to start the hot chemotherapy inside the abdomen, that is when we will give a little, sort of like communication to the anesthetist. Boss, I'm going to start the HIPEC in about half an hour or 1 hour so you can start cooling the patient. Why this is needed? Because at the time of HIPEC, giving this hot chemotherapy, we have a lot of sort of like what we can call as the hot agents which are going to circulate inside the abdomen, and we need to cool down the patient. So the normal temperature during HIPEC is going to be maintained at between 42 to 43 degrees centigrade, almost 6 degrees above the normal temperature. Now, when this is happening, we need to ensure that the patient doesn't get too heated up. And for this, we cool the patient by giving ice packs, by giving circulation through cool solutions and all that in the rest of the body. And all this is going to be done, and it is going to be planned for on a regular basis in anybody who's going to undergo a HIPEC. Now, this HIPEC, the circulation time is going to be about 90 minutes. So at the time the hot chemotherapy is going to go, for those 90 minutes, we have to maintain the temperature normal. So up and down a game kind of thing is played so that either the patient is warmed up or cooled down as the requirement is, so that the temperature can be maintained at a normal level. So this degree of coordination, while some degree of coordination is needed in all forms of treatment, in fact, in our day-to-day life, for everything we need coordination and communication. The level of coordination and communication which is needed in oncology is going to be far, far higher. Each and every step of the way involves coordinating with interdepartmental heads, making sure that all the patients are getting the right treatment and they are coming for the right planning at the correct point of time, so that there is no lack of continuity in the treatment. And that is going to be the whole essence of cancer care and oncology. It is not just about treatment, it's about coordination, communication, and also continuity. So on this World Cancer Day, February 4th, 2026, I, from the Department of Oncology at the Gleneagles Cancer Institute in Chennai, request each and one of you to take a pledge to try and look after your health as much as possible. It involves pretty simple things: getting your daily diet under control, ensuring that you do not have any bad habits like smoking or alcohol. You can stop all those, give away your addictions. Do a bit of exercise. It can be as simple as walking for about 15-20 minutes a day. Nothing else is needed. If you do that on a regular basis, a fast paced walk is good enough to keep you healthy. So all these things, if they are done, and in concurrence with that, if we are also going to do screening tests and get the vaccinations done. So for cancer, we do have a lot of screening tests which are available. Like it may be mammogram for breast cancer starting from the age of 40 years. I like to give this in my talks. Like think about 30, 40, and 50 as the numbers you need to remember for cancer screening. Roughly from about 30 years onwards, every 3 years, 30 years, every 3 years, every lady needs to undergo what is known as the pap smear to identify early cervical cancer, the uterine cancer that we talk about. Then from the age of 40, every year, annually, you do a mammogram of both the breasts, which is an x-ray of the breasts. So that needs to be done once in every year from the age of 40 years. And from the age of 50 years, we need to plan for colon cancer screening. So that will be done once in a decade. That is enough. So once in a decade, you do the colon cancer screening. And all these three, when we do, the chance of eliminating or identifying the very early cancers is pretty high, and we can achieve success. So here is to wishing you united but unique and a cancer free life ahead. Thank you, my friends.